Bueno, vamos a continuar. Es un honor tener a Judy aquí. La jornada promete igual que la de ayer, con una altísima calidad. No solamente aquí adoramos a Pepín Banzo, sino que adoramos a una mujer que se llama Irene Vallejo, a la que vamos a escuchar y a saborear dentro de unos minutos. Pero ahora mismo la persona invitada nos la va a presentar nuestra compañera. Ha venido de San Diego, es una mujer que conoce muy bien de qué estamos hablando. Su investigación versa sobre una vida dedicada precisamente a la atención de las personas, de la familia como centro, y nos lo van a explicar a continuación. Esta es una cita con traducción simultánea. Todos tenemos este aparato, tenemos que pulsar el canal número 1, aparecerá, parezco una azafata de aviación, me encanta que sea así, aparecerá la cifra 883 ahí, y es ahí donde vamos a recibir la traducción simultánea. Este mismo aparato lo vamos a necesitar a las 3 de la tarde porque también habrá una intervención en inglés. Pero nos recuerda la organización que cuando termine esta traducción devolvamos, por favor, el aparato y lo volvamos a adquirir a las 3 de la tarde. ¿De acuerdo? ¿Sí? Así que ahora, de momento, utilizamos efectivamente esta traducción, canal número 1. ¿Vale? Os dejo con nuestra compañera. Es Laura de la Cueva, enfermera de la Universidad de Barcelona, miembro del proyecto UCI en Barcelona. Ella es la que va a presentar a Judy y arrancamos con mucha altura esta jornada de viernes. Laura, cuando quieras, adelante. Muchísimas gracias.
Muchas gracias, Juanjo. Buenos días. Bueno, después de la fiesta de ayer toca despertarse porque comenzamos con uno de los platos fuertes de este congreso, y es que, tal y como ha dicho Juanjo, que ya lo ha introducido muy bien, es un honor para mí presentaros a la doctora Judy Davidson, especialista en cuidados críticos, que actualmente trabaja como enfermera científica en el sistema de salud adscrito a la Universidad de California, San Diego, donde se dedica a dar soporte a enfermeras, a más de 5.000 enfermeras, ¿no?, en la adquisición de habilidades de investigación, de presentación y de publicación de resultados. La doctora Davidson fue premiada por la Society of Critical Care Medicine por sus grandes contribuciones al cuidado centrado en la familia, y lo cierto es que podría hablar durante minutos y minutos o incluso horas sobre sus aportaciones, pero creo que lo que es verdaderamente interesante es que ella nos explique este legado científico y el trabajo que fundamentó lo que hoy en día son los estándares globales para cuidar a la familia. Judy, cuando quieras.
Me gustaría agradecer a Dr. Gabriel Ares en la Fundación por invitarme a esta oportunidad para hablarles a ustedes hoy. Desafortunadamente, no hablo español. Y lo siento por los que van a necesitar intérprete por mi presentación. All right. So today I will talk to you about family-centered care, and I promise to inform you of items that you will not be able to read in the publications, secrets behind the scenes. And I come to you from sunny California, one of our beaches, and the hospital where I work. My objectives today are to talk to you about the practice guidelines that we developed through the Society of Critical Care Medicine, the development of post-intensive care syndrome, and a theoretical framework that I developed for nurses called facilitated sense-making. But first, I'd like to tell you a story. I've never told this story from the stage. It's a very personal one. About the same time that I was developing the first set of guidelines with the society, my daughter was only 15 years old. She was in school in a marching band, and she traveled 2 hours north from the house for a competition. And I received a call from the leader of the band. "You need to come get your daughter. Something is terribly wrong." My husband and I drove the 2 hours away from our home and picked her up and put her in the car. She did not recognize us. She could not sit straight in the car. She kept falling over. She could not see. Something was terribly wrong. We drove her to the hospital, the Children's Hospital in San Diego, where she was admitted. And I was in the room, and the doctors were presenting their rounds outside the room. I could hear them, but I could not participate. I could not add to the conversation, and I learned, and I was frustrated because their differential diagnosis, there was something wrong, something off. They thought she had one of two conditions. She's 15 years old. They thought she might have been emerging bipolar, the right age, but not the right presentation. That's not the way bipolar disease looks. Then they thought maybe she had been drugged at the band concert, but her toxicology screen was negative. That's not the way that presents. And I couldn't shake the fact that the day before I had started her on a new medication, minocycline, a tetracycline, for acne. So I went down to the library downstairs, the medical library. They let me in even though I was just a patient's mother. And I took out the compendium for drugs, the physician desk reference at the time. So many years ago, there was no Google. And I looked up the drug, and there it was at the bottom of the page in bold warning, this drug can cause pseudotumor cerebri in rare cases with cortical blindness, cerebral ataxia. I made a copy of the page, and I brought it upstairs, and I asked the head nurse to muscle me into rounds so that I could present a possibility that that is what was wrong. I did attend the rounds. I gave the page, the Xerox page, to the doctors, to the senior doctor. He looked at it, he looked at me, he changed the diagnosis and her treatment, and days later, I brought her home. Family presence on rounds. At that moment, I knew we can do better. We can do better, right? So this was the same time we were developing the practice guidelines. And you can see here the short list of names of people that we gathered together and reviewed the literature. It was a standard review of the literature at that time, not a systematic review the way we do today. But the most important thing was, before this moment in the early 2000s, most of the literature written about family-centered care was written by nurses. The physician colleagues on this paper were reading this literature for the very first time. This was a nursing thing, family-centered care, way back then. My goal in writing the guidelines was someday this would be interdisciplinary and just as much focus from medicine as nursing, and we would work on this problem together to improve the situation for families. So 6 years later, I was doing a mission trip with the Society of Critical Care Medicine in Africa, and we did a safari, a photo safari, and I was sitting in a Jeep. These are the secrets I promised you. I was sitting in a Jeep with the president of the society, looking at zebras and lions and trying to find a leopard. And I said to her, the guidelines are expiring. They're more than 5 years old. Professors in the university will not let people cite them anymore. They're too old. And I know that a lot of literature has been published since we first published the first guidelines. We should start again, shouldn't we? And she said, sure, let's do it. So she allowed me to assemble a team. I looked up every author I could find that I had trusted and respected over the years on the topic, gathered them together. Now look at the long list of names. We published the second set of guidelines almost 10 years to the day after the first in 2017. And this time we invited global authors. Only, unfortunately, we did not have representation from Spanish-speaking countries. I am proud to say the third set of guidelines was published last month, and we corrected that problem. And your own Dr. Aris is a key author on that document. He is a hero amongst you, representing your country with these international guidelines. So, did these guidelines stimulate further research? Are physicians and nurses and therapists now working together on this problem? Well, look at this. Since the first guidelines were published, over 9,000 papers have cited the work and produced further research to carry on this mission. Just amazing. You see the slow, steady rise at the beginning after the first set of guidelines, and then a steep jump in the research after the second set were published. So we achieved our goal to come together as one to address family-centered care. Ignore the drop at the end. That just means 2025 has not happened yet, right? We don't have that. So a little bit about some of the unusual features, maybe even controversial, of the first set of guidelines. And there we, by consensus statement, and looking at the evidence in the literature, due to the absence of harm and only evidence of good of what a patient's own pet dog may do to help with healing, we put in a recommendation that patients' pets should be allowed to visit in the hospital. Okay? In the second set of guidelines, another secret I will tell you is that my co-chair, Dr. Randy Curtis, esteemed Dr. Randy Curtis, he said to me, we're not going to address pets in the second set of guidelines. I'm afraid if we put animals in there, my colleagues that are old-fashioned, they'll throw out the whole set of guidelines because they won't believe in it. So we can't address animals in the second set of guidelines, and we didn't. I made the compromise. But the second set of guidelines has one sentence at the beginning. It says, none of the previous recommendations have been refuted, so that all of the guideline recommendations from Series 1 in 2005 still remain active today, including we should consider animal presence to assist with healing. Now, we do get a lot of resistance on this idea because of fear of infection. Fear of infection. There is no documented case that a patient's dog has ever infected a patient in the hospital. Okay, in fact, the only thing I can find is that we infect patients in the hospital. Maybe we should be restricted, not the patient's own pet dog. Okay, but Rob Knight, a famous investigator in the United States, conducted a study called the American Gut Project, and I would like you to consider this. In his study, the American Gut Project, he looked at the microbiomes of animals, the pets, and the owners of the pets, and the whole family. And they found that over time, the microbiome of the pet starts to match the microbiome of the owner. And so I have a hypothesis that maybe one of you in the audience can test with future research, is that you are less likely to become infected from your own dog than those strange dogs the volunteers office walk around the building for everybody to pet. Okay, so future research, that could be you. So I'd like to now tell you a story, and I might need my notes a little bit for this one. I'd like to tell you a story. When I was manager of an ICU, I used to collect exemplars, and then at night, instead of only the people that day learning from that experience, I would type up the story and send it to the entire staff and faculty so everyone could learn from the case. And this one I call The Best Death. It all started with Teresa, who's up here in the corner, a nurse who was not even there on the day that it happened, but she had the foresight to clear the path by asking to make sure that it was allowed for the patient's own pet dog to be present for the patient's death, and that the patient could die outside, as he had requested, in the sunlight on a special day. He had neuromuscular disease, and he did not want to live forever on a ventilator. And when it became clear that was the only way he would be able to live, he asked for withdrawal of life support. So the respiratory therapist, she found a therapist and a nurse that would work that day, the next day, to handle this situation. And they ambu bagged the patient and wheeled him outside. And his dog, who had lived with us in the ICU for the last 2 weeks, came with him. Outside in the sunshine, on the anniversary of the day that he and his wife met, he was extubated and he died. His dog grieved. You could see the mournful nature of his eyes. Everyone cried. The dog cried. We cried. Everyone who heard about this case for days thereafter cried. The backyard of the hospital was backed up to across the parking lot is a church. And the moment that he died, the church bells rang. It was such a special moment for all of us together, us, the dog, the family. He had Native American culture, and the family performed rituals according to their culture. They put a stuffed bear underneath his arms because the bear in their culture is a symbol of a healer. The bears know to bring healing fruits and vegetables from the forest and use them wisely. And the patient had been a doctor in his life. The best death. So these are the things we can orchestrate with family-centered care if we think about it meaningfully and apply humanization, right, of care in the ICU. About culturally competent care. Now, the first set of guidelines had a section on this, but the third set that Dr. Harris and his team have recently published have a stronger recommendation now that we address the language issues, translation and interpretation, so that we can enhance communication for our patients who are the non-dominant culture. The patients and their families have the information they need in the language that they prefer. Next, about family presence at rounds and resuscitation. Now, family presence at rounds and resuscitation has been a recommendation because of strong evidence in the literature since the very first set of guidelines. All 3 guidelines address this, all 3 guidelines recommend this, and in every country in the world, all across the United States, there is resistance to making this happen. And the resistance stems largely from what if. People who haven't done it worry about so many things that do not happen when you try this, okay? I read all of the literature on this. I've written several papers on this. I even wrote an editorial called What If? Okay, the what if factor. People that actually do this endorse it. The biggest issue is that we don't it does cause stress if you're not prepared for it. So as a clinician, you need to prepare for how to have families presence on rounds and resuscitation. In all 3 guidelines, we endorse the practice, but we don't tell you how to do that. The reason? The best practice is not yet known. So we need one of you in the audience to start studying what is the best way to teach doctors and nurses and therapists how to include families present on rounds. Once we have that evidence from one of you in the audience, we can pull that forward for the 4th set of guidelines and actually encourage people to do it your way, all right? So about post-intensive care syndrome. This construct was developed in 2010. It was not in the literature before that, and it happened because of this group of people. You see in the middle, there's me before I turned gray, okay? With my pigeon toes facing each other, all right, smack in the middle. And then there's Dale Needham at the end on the right-hand side. He was first author of the paper, brilliant man, and a great writer, great author. And Maureen Harvey, the past president of the Society of Critical Care Medicine, whose idea it was to bring us all together to talk about long-term consequences from critical illness. So that was a mouthful, long-term consequences from critical illness. Dale presented the state of the science about patients and their long-term consequences. I presented the state of the science about families and their long-term consequences. Then we were supposed, our task was say, what next? What do we do next? Well, you're wondering why I have a picture of an X-ray on the screen, right? The reason for the X-ray, a long time ago, history tells us, radiologists said There's a pattern to the way that bones break when somebody's been beaten, when a child has been beaten, rather than if a child falls down the stairs, okay? And they said, nobody will ever pay attention to this unless we give it a name. So they gave it a name, battered child syndrome. Now you're all familiar with this, right? Ever since the radiologist gave this constellation of findings a name, now the doctors can point to social workers to give the right therapy for the patient's social problems as well as their physical problems, right? So we said we have to take a page out of that book. We have to do the same thing with long-term consequences from critical illness and come up with a name. So we sat around a table and tossed around names until one person, Mona Hopkins, she's third in, she's a nurse from Salt Lake City, United States. She said, what about post-intensive care syndrome? What do you think about that name? And we said, brilliant, let's do it. And I said, what about post-intensive care syndrome family, for what happens to the families? And everybody said, great, let's do it. So we made a proposal to the board of the Society of Critical Care Medicine, and they accepted it, and it was born, okay? So that's how post-intensive care syndrome was born. You've probably seen this model. It's very common and published in many places, showing that the family has mental health issues, the patient has mental health, cognitive, and physical issues that may last a long time, years or forever, after their experience with us in critical care. But no sooner had I published this document that I received a message from a student in the UK who told me, hey, you sold the families short. The families have more than just mental health problems after they leave us. And I went back to the literature and I combed through every document again that we had used to create the guidelines. And lo and behold, that student was right and we were wrong. And I put together a new model. Now you'll never find this. It was published in a book that is no longer in print. So you can have these slides. The foundation can share these slides freely with all of you. Use this model for a post-intensive care syndrome family that shows that the family can have mental health problems, yes, of course, physical problems, cognitive problems, and social strain that all affect the quality of life for years to come or forever. And as an exemplar about this, let me tell you a story. About the same time that we were developing this nurse walks into my office and she has a brace on her foot and she comes into the office, clunk, clunk with the brace. She's supposed to be on a leadership internship with me, studying leadership skills, how to manage intensive care, right? Not work at the bedside. And she's supposed to be wearing business clothes. Well, she says, I can't, I have to wear this special boot. And I said, sit down, tell me why. It's okay, no problem. So she starts to tell me her story about her year as a patient in the intensive care unit. She had driven home from work as a nurse and a drunk driver hit her car and ran it over. And she was a trauma patient. When she was in the ICU, she could not move her arms or legs. She could only move her thumb to use the call button. And after she was extubated, she could barely speak and make her needs known. But she was dependent on the staff for many months. She spent a year in the hospital, 6 months in rehab. Now she was working on her next degree, hoping to get a desk job in nursing because it was difficult to work at the bedside. And she told me that at night, the nurses would make her mother go home. In the daytime, the doctors would tell the mother she's likely not going to survive. So the mother didn't want to leave too far. She was so afraid her daughter would die in the middle of the night. So she rented a van and slept in the van in the parking lot of the hospital every night instead of going home. And Jessica used the call bell one night and said, please, nurse, call my mother and have her come in. I'm fearful, I had nightmares, I need my mother. And the nurses thought she was too sedated to remember the request and never got her mother. She said she laid there at night and watched the second hand go around in the clock, around, every minute, 1 minute after the next minute, 1 minute after the next minute, 1 hour after the next hour. She was traumatized for life over that. She's talking to me 3 years later. She tells me she's still receiving psychotherapy for that forced separation from her mother, and that night she spent alone after she had asked for her. The mother I interviewed for my study on facilitated sense-making, and she told me similar horror stories. She was so afraid to leave her daughter that one night, the mother was a nurse, she went to the supply cabinet and took a urinal and went behind the curtain in her daughter's room and stood there all night and peed in a urinal to hear her daughter breathing, to make sure she was alive. She said that was very uncomfortable. I tried another approach another night. I crawled under the bed, and I laid under the bed on the cold, hard floor. And I raised my hand, when nobody was in the room, I raised my hand up through the side rails to hold my daughter's hand in the night so she would know she was not alone. And when someone came in to care for her, I took my hand back down and I crossed it across my chest and prayed I would not be found. And I thought to myself, we can just do better. We can do better. So I took Jessica with me to Chicago to tell her stories. We had other patients and their families come too to develop the construct of post-intensive care syndrome. And I took her to the airport, and her mother drove her there, and it was the first time they had been separated since the hospitalization. And Jessica and I go through security, and we put in our ticket, and we get through, and we are on the other side, and the mother starts running to the gate, running towards security, trying to go through to get to her daughter. She's screaming her name. The security guard tackles her and takes her down, and she's screaming, and Jessica and I are on the other side. And I looked at her, and in that moment I known we had broken these women. We had done it, not the car accident, not the drunk driver. It was us, and we can do better. We can do better. Right? That's what family-centered care is all about. We can prevent these traumas. We're there in the moment when these traumas occur, and we can prevent them. So post-intensive care syndrome really took off. There's been over 2,000 articles citing this work and people all over the globe studying ways of prevention at this point in time. At the same time in history, we asked the society to add to the ICU Liberation Bundle an F for family, and they agreed that this was important enough to add to our essential core component. The family is no longer an option. The family is part of the care. They are inseparable, the patient and the family. We cannot forget them. We do need to include them in our care. So next, I developed this theory for my doctoral work called facilitated sense-making, meaning we need to help families make sense out of their new situation as caregiver of a critically ill husband or wife or child. So for all nurses in the room, nurses, raise your hand, nurses, okay. You can find every nursing theory that was ever written at nursology.net. Okay, if you ever want to look up nurse theorists, and now nurse theorists are not scary people. Look, I'm one of them. I'm a little gray, okay? I'm one of the theorists alive today. If you go through that list of theories, nurses, and find that there's a Spanish theory that's missing, write to the webpage authors. They will gladly include it, okay? So that's a compendium of nurse theories. So about facilitated sense-making, it's a mid-range theory, meaning that it's prescriptive in nature and gives the nurses exactly ideas to do at the bedside to help families and protect them from these traumatic harms. So the simple way to say it, they need to make sense. Families are exposed to critical illness. They need to make sense out of what's happened. They need to make sense of their new role. And depending on how that happens in the middle, they can either cope or they can be traumatized. And I posit that it's up to us, the difference between the two. What happens in the middle? We can manage that with facilitated sense-making interventions. There are things we can do to help them cope. So why should this work? Why should facilitated sense-making work? Well, the way your brain works in the limbic system, when something fearful happens, the amygdala catches that signal, something fearful happened. The amygdala passes it to the hippocampus, and that hippocampus contextualizes this, says, how fearful is this, right? And then that goes to the prefrontal cortex, and the prefrontal cortex picks up old memories of how you coped in the past and brings them forward. if you have coping mechanisms from the past, if you have no built coping mechanisms from the past, that's when you see someone sitting at the bedside, rocking in fear, and the traumatic memories are forming inside of them, and danger happens, right? I posit that we are all there in these moments. We are there in their moment of crisis, and we can abort this limbic system response through helping them with the precursors to post-traumatic stress. Precursors, fear, horror, and helplessness, right? So we can address fear and horror, fear of the unknown, by communication, by clearly communicating what's happening, helping them make sense of the situation, so they're not rattling in fear of the unknown. Helplessness, give them something to do. Give them something to do. And by giving them something to do, keeping them busy with known tasks, easy things that they don't have to learn, it can help them cope with the situation. And a Professor Weick, who had an organizational sense-making theory from business, said, we define ourselves in crisis by what we have done in crisis. So with families enduring this crisis, if we give them things to do later, even if the worst happened, even if death happens, they can say, I did everything possible to help my husband, right? So we divide facilitating sense-making interventions into 4 categories: things we can do to help build caring relationships with the family, things we can do to communicate, things we can do to help them with presence and engagement, and things we can do to help them, if they want, with decision-making. Not all families want to be included in decision-making, but for those that do want to be involved, this can help them cope. And let me tell you another story. I embedded myself in the ICU for 45 days when I tested this theory. And I met with, I enrolled families, and I met with them for 3 days in a row to see how the interventions were working with them. And I worked in a faith-based hospital. There's about 17 hospitals in San Diego. 1 is faith-based. This one, when you walk in the lobby, there's this oversized statue of Jesus nailed to the cross. You cannot miss Jesus when you walk into the hospital. Right below Jesus' left arm is the chapel, right? So I talked to the family that I enrolled in the study sitting at the bedside, and I gave her a list of ideas, things from Moulter and Lesky, famous work by a nurse back in the, I think, 70s, a list of family needs. And I said, are there any of these things that we can help you with? And she looks at the list and she said to me, I didn't know you had a chaplain. I'm thinking to myself, how could you not know that we would have spiritual care with Jesus this large in the lobby, right? How could it be? Well, sometimes in the moment of crisis, the obvious escapes them. So we have to get to that level of communication with our families to help them through this crisis. So I didn't know you had a chaplain. All right. The other thing that really disturbs families are alarms in critical care. And I developed this little easy system for teaching the staff how to talk to families about the alarms. Think about your house. You have think about your house. The clothes dryer has an alarm, and it rings. When you bake a cake in the oven, you can set the timer, and it rings. When there's a fire, the smoke alarm rings. They all have a different sound. You know the difference between the dryer and the smoke alarm, right? That's the same with our alarms in the ICU. If the nurse doesn't come running right away, it's because it's the clothes dryer. What's going to happen if the clothes sit a few minutes? They might get a little wrinkled. Nothing big will happen. The cake, you've got about 5 minutes before the cake is overdone. But a smoke alarm, they're going to come running right away. So this is the same thing with our alarms in the ICU. When I explain this to families, you should see, they're like this. You explain that, they're like, oh, like this. They relax right away when you explain this about the alarms. It's a key point of our care that it needs simple instruction. Now, about spiritual care, this might surprise you. The first set of guidelines went further than just we should offer spiritual care to our families. It says here, and this is maybe be a little controversial, I don't know. We may include in our own practices spiritual care as doctors, nurses, and therapists. If the families want prayer and you are comfortable praying, it's okay. It's within your scope of practice, but only if you're comfortable and want to, and they want it as well. You don't have to run and get the chaplain, the nun, the priest. You can offer spiritual care yourself. So should we include, but many doctors, nurses, therapists are uncomfortable with this, especially if there's people of many different religions in your hospital. How do you know you'll say a prayer that won't offend them, right? Like given their unique religion and faith. So I worked with the clergy to develop a pocket prayer that was agnostic, any religion, right? So should we have this kind of training for our staff? The prayer goes like this, but you can edit it shorter, longer. Dear Lord, we pray today for Mrs. Garcia, that her day be a day without pain, a peaceful day. We pray that the doctors and nurses and therapists and all who care for her do so through your hands with wisdom and compassion. We pray for the renewal of her body and spirit. We pray that she feel the love and comfort of all those who pray for the ill and injured. We pray for this in your most holy name. Amen. Okay. But in reality, every time a patient or family has asked me to pray with them, and they reach out their hands and you hold their hands in solidarity, they usually lead the prayer. You don't have to lead the prayer. You just have to be there for them, empathically listening in prayer. So spiritual care, it is within your scope if you want it within your scope. So giving them purpose at the bedside, what can we do? In the facilitated sense-making model, what I did was I made a little kit and I gave one to each family and I just watched to see what they would use out of the kit. And you're probably laughing that I put games in here, dominoes and playing cards. Well, it's not about you playing games at the bedside. It's about take the night table, the bedside table, and put 3 dominoes on here for a patient that's slowly awakening, getting stronger cognitively, and having the family say, hey, Dad, point to the domino with the most points on it. Point to the playing card with the most points on it. So you can use the dominoes cards that way instead of using the real games. Often with comatose patients, I would find the families actually playing solitaire at the bedside. Now again, that keeps the limbic system disengaged, right, with a known activity. So who cares that they're playing solitaire at the bedside as they're sitting vigil? The most commonly used item, chapstick, for the lips, putting lip balm. Families are obsessed with the lips of the patients that are on a breathing machine. I think all the nurses are smiling in the room and nodding their head. The families are obsessed with this, and no, they never touched the ET tube. They never bothered it. They knew not to bother it. They loved having their own chapstick to be able to moisten the lips and take care of the lips. Now the pencil, I had first put a mechanical pencil. Everyone told me they're too hard to use. Just put a regular lead pencil in there. Then one family was brilliant. One family gave me the red foam grip from occupational therapy in the middle. That red foam grip, when you put it on the pencil, I had people that were awake on a breathing machine, on the mechanical ventilator. 6 out of the 7 next patients could write, who could not write before. You know how they have that little micro writing that goes like this off the page when they try to write a message for you? As soon as I put that foam grip on the pencil, they could write. Then the communication between the patient and the family improved, and everybody's anxiety goes down. So the kit. So my favorite participant in the study or subject in the study was this man. He told me that he was a street fighter from Mexico, okay, that we live only about 10 minutes from the border. So he was a street fighter. His little brother had stolen his motorcycle from him and taken it on a joyride without a helmet on. And he had gotten in an accident, and now he had an ICP, he was in a coma, his little brother, and here he was. He told me the same exact story that Jessica's mom told me about being forcibly separated to go home at night. He said, I could not leave my brother. I was so guilty he took my motorcycle. This is my fault. I could not leave him. So what I did, when the security guard comes around and clears everybody out after 10 p.m. at night, he would go in the bathroom and crouch on the toilet, a grown man crouching on the toilet to hide, because a security guard could not see his feet from under the door, and he waited till all clear. But then, lo and behold, his brother's ICU room was on the other side of the wall. So you walk out of the ICU, around the corner, there's the bathroom. Walk back in, the first room was his brother. So what he would do at night, crouched on the toilet, is lean and listen into the wall, and he could hear the whoosh of the breathing machine as his brother was breathing, right? And knew his brother was alive. And I thought to myself, we can do better. We can do better than that. When people need to be with their family, we should allow them to be with their family. So I gave him that little kit, right? And he, the patriarch of his family, he goes out to the waiting room, and he takes the kit out to the waiting room, and he says to his family that are gathered around, he says, this is what we're going to do. This is what we're going to do. He says, Mom, you pray. And then he tells his brother this, his sister this. He gives everybody a job out of the kit. Now he has tools, and he has action, and he can take charge. It was beautiful to watch. And then I said to myself, I wonder what he's going to use out of the kit. So the next day I go to visit, and what is he doing? Giving his brother a pedicure. Okay, I would have never guessed this big burly man sitting there filing his brother's toes. And he says to me, when he gets out of here, Nurse Judy, he's going to be a lady killer. So it gave him hope, gave him something to do, kept the limbic system involved, right? Out of engaged, disengaged, and towards healing. I know I've come to the end of my time with you. I could tell stories all day long, but I want to say that you are the future. You are the future. You're the most inquisitive amongst us because you're here today. You've heard about things that need to be studied. We need to know the best approach to teach nurses, doctors, and therapists how to engage families on rounds, how to engage them in resuscitation, how to have them present in resuscitation. There's all kinds of things we could do with animal presence. Did you know that if you look in a dog's eyes for 1 minute, it releases oxytocin? This is a documented fact. And oxytocin releases the love hormone, and that it improves your capacity for compassion. I wonder, I posit, I hypothesize, and one of you can test. You know how you have to go in and give patients the bad news or give family the bad news as a doctor? Right? You know how you have people at work that might be challenging to work with, and you know it's going to be a little fight? What if you had a picture of your favorite dog in your phone, and you looked in the dog's eyes for a whole minute before you go into the family conference? Will it boost your oxytocin so that you can engage with compassion with that family in a more meaningful way and protect you along the way? We heard meditation yesterday in the lecture, but there's another idea. They're countless, they're endless. There's so much more to be studied and so much more to be done. Now, I hope I have a few minutes for questions.
Muchas gracias, buenos días por la ponencia, ha sido preciosa, me ha encantado. Quería consultaros porque del otro lado, para los animales, para las mascotas, hace poco leí un artículo, yo soy voluntaria en una protectora de animales y leí un artículo en el que decía que había varias asociaciones en España, protectoras de animales, que estaban intentando recoger firmas para conseguir que cuando el amo del animal fuera a fallecer en el hospital, se le permitiera al perro no solo estar a su lado antes de morir, sino incluso ya muerto, que pudiera olerle, estar con él y percibir que se había marchado, porque si no, para el propio animal era traumático el sentirse totalmente abandonado, sentía que su amo le había abandonado, no había vuelto junto a él porque no había podido experimentar la despedida de su amo. De hecho, en el Hospital San Rafael de Madrid hay una escultura muy bonita de un perro que está esperando en el césped a su amo porque bueno, los médicos y los enfermeros recaudaron dinero para hacer esa escultura porque fue un perrito que siguió a su amo detrás de la ambulancia corriendo por todo Madrid. Lo hospitalizaron, pasó varias semanas, falleció, el perrito nunca se separó de la parte de abajo de la ventana del hospital y se quedó allí hasta que murió, como en la historia de la película del perro japonés de Richard Gere, ¿no? Mi consulta es si vosotros habéis tenido alguna experiencia en este sentido o hay alguna iniciativa en Estados Unidos o similar a esta iniciativa que se está intentando promover en España en el sentido contrario, ¿no? Para los animales. Gracias.
Thank you. Thank you very much for your story. I believe this happens. We do not have a structured approach, except that we have a policy that says the patient's dog is always welcome, right? So we would not have prohibited the dog from visiting. And often we can arrange, if there's, the hard part is that the dog has to come with a human. If there's no human to bring the dog, I've known nurses to take it upon themselves to help with the situation. Yeah, so that they can see each other and the dog and the owner mutually benefit from this situation. Yeah. But I think you brought up another area for future research.
Creo que por aquí había otra pregunta.
Por aquí había una antes.
Ah, vale, perfecto.
Muchas gracias, Judy. Yo me declaro miembro del club de fan de Judy Davidson desde los inicios, desde las primeras guías. Las utilizamos desde las primeras de 2004, 2017 y ahora la de 2025 en muchas formaciones, y muchas veces en esas formaciones nos sorprende especialmente que contamos con evidencias que se van renovando acerca de muchos aspectos. Siempre ponemos el ejemplo de la reanimación cardiopulmonar y es casi obligado formar periódicamente a todo el mundo en reanimación cardiopulmonar, ¿no? Y todo el mundo sabe cuándo cambia la secuencia de ventilación con presión, porque claro, se ha publicado en una guía, hay que estar actualizado y hay que adoptar esos cambios, ¿no? Sin embargo, tenemos la guía de Judy Davidson de 2004, actualizada en 2017, actualizada en 2025, y nos da la sensación de que no se concede la misma legitimidad a unas evidencias que a otras. Y no sé si en ese sentido, en vuestro ámbito concreto, tenéis programas formativos que obligan a los profesionales a actualizarse también con esas guías, también con esas evidencias que no son exclusivamente técnicas, no son reanimación cardiopulmonar, manejo de antibióticos, ventilación mecánica, pero que lógicamente contribuyen a la mejoría de los pacientes. Muchas gracias.
Yes, it does take it takes a leader to, It takes a leader to address this. We don't have a standard approach in the United States. In my own hospital, we started adding family to the simulation for resuscitation training. So we have simulations for resuscitation where people practice the CPR and the breathing with a bag, and then the family member comes in with a nurse, right? So we've actually added the family as a role in simulation during the initial training for doctors and nurses to learn resuscitation. But this is just one hospital, not a standard approach. I think you've been developing some good scenarios for teaching staff how to have family presence that could be standardized and become a global standard. You are our future. I think the work you're doing is exemplary and far surpasses what exists anywhere else. Oh, yeah. Thank you.
Gracias, Judy, por la presentación y hacernos recordar, ¿no?, la importancia de la familia. Mi pregunta va dirigida a, un poco siguiendo el hilo del profesor Velasco. Podríamos decir que una parte es a veces la falta de formación, ¿no? Pero hay otra parte que hay una parte de resistencia por parte de los profesionales a incluir a la familia dentro de los cuidados, incluso que sean cuidados por las enfermeras, ¿no? No solo que participen en el cuidado de los pacientes, sino que nosotros como enfermeras y enfermeros cuidemos también a la familia. Entonces, la pregunta es muy sencilla. ¿Cómo podemos convencer o cómo podemos hacer que esa resistencia disminuya? ¿Qué estrategias nos recomiendas?
Yes, I think establishing the culture that family and patient are inseparable, that it needs to be done from the top with leadership and role modeling. At some point, I'm wondering, do we hire for professionals that are compassionate enough to deal with families? When I was testing the facilitated sense-making model, I found the nurses divided in thirds. There was a third that knew how to deal with families intuitively. It was part of their nature. They just did it. There was a third that wanted to learn how to do it because they didn't know how to engage with families, right? And the younger generation that was brought up on the cell phones, they need more help with the face-to-face communication, right? And sometimes even scripting on how to say and what to say and when to say. But you're right, about a third of the staff were resistant. The family is not my job. I was hired to care for the patient. And here, I think it's consistent role modeling. It needs to become part of the unit standards, right? The behavior standards, that we treat the families with kindness and engage them in the care. And eventually, can we hire for nurses, doctors, pharmacists, the therapists who are like-minded in this way, right? Yeah. So it takes, you get to a critical mass, you get to a certain point, you have, if a third are already doing it, get a little more, eventually you overcome the resistance. You have to get to critical mass and set the culture with a strong leadership. And the guidelines were meant to help do that, to give you something to fall back on as a document to say our professional societies endorse this for good reason. There's evidence behind these statements. So that's the guidelines you can hold up to help support the shift in the culture. When I was manager of an ICU, when I came in the morning, I went to the family waiting room first, and I did rounds with the families. Anybody that had spent the night, obviously, was probably visiting the sickest amongst us, because if you give them the option to spend the night, it's only the ones that are related to the sickest, the ones that are near death. So I did family rounds first. You role model it as a leader, and then everyone will follow suit in the end. Yes, Gabby.
Sí, bueno, yo quería decir que, primero, Judy, agradecerte que has venido desde San Diego a nuestro congreso. Judy se jubila en 2 meses y tengo que decir que este es su último baile, esta es la última conferencia que va a dar, así que creo que... Bueno, como ves aquí somos personas muy apasionadas y muy inspiradas por ti, por tu trabajo, y me gustaría preguntarte, después de 30 años dedicándote a la investigación como mujer, como enfermera, siendo una referencia internacional para todos los que trabajamos en atención centrada de la persona, ¿qué consejo le darías a cualquiera de nosotros que puede estar empezando en su unidad, ya sea de cuidados intensivos o lo que sea, para trabajar y expandir este modelo sin que se sienta que está solo y sin que se sienta que es el raro, ¿no?, del servicio? Muchas gracias.
Yeah. So kind of you to say only 30 years. It's been 40, 45. So, so kind of you, even with my gray. But I started conducting research in 1984 with a good mentor. For all of you mentors, take someone new under your wing, guide them along the way. Don't wait for them to have the right degree, right, or the right credentials. I had none of the above when I started conducting research. I just had a good mentor. Every year since 1984, I've been conducting one study after the other to answer small clinical questions, very small questions, but they add up over time. Use your one small voice, ask your one small question. That question will lead to the next. Surround yourself with good mentors. Take their advice. Partner together, nurses and doctors. My favorite experiments have been when I teamed up with a doctor at work, and the two of us conducted a study together. The guidelines written, I was lead author on the first two, and my co-chair was a physician. Teaming up together, we're stronger together than separate, and we are more alike than different. So mentors, team up together, use your one small voice, and ask the questions.
Muchas gracias, Judy. Es un honor. No me dilato más en la despedida, porque además Gaby ya me ha robado todos los argumentos. Y mil gracias, Judy. Muchas gracias a todos.
Gracias, muchísimas gracias.